Chitran and Andrade, helping me out in a big way. And now the researchers are really lucky because many such programs are happening, and IPS Karnataka in general and Journal of Psychiatry in particular have taken up this particular job in a big way. What has been actually thought of, planned, and ultimately the outcome would be something exemplary, and I'm more than confident it will be almost like a landmark thing in the publication. Dr. Herbie Shetter had told me that all of these things are going to be of very definitive use, and more particularly even the physical workshop which is being planned. This actually prepares the individuals for that particular job. Though a limited number of people are there in this particular program, it only shows the solid people who are there, who are going to carry on this particular job. This is not the matter for everybody. Only few people have that. One is passion, idea, interest, and only those people can do this particular job. And to refine their talent already what they have, these programs are really beautiful. And Ravi Philip Rajkumar, long back I had seen him, almost 10 years ago. That's what actually he was telling. And I'm really very happy that this particular job is being done by him to help us all. Thank you very, very much for this invitation, and I'm more than confident this will go a long way in strengthening academically and research-wise IPSKC in general and our journal in particular. Thank you very much.
Thank you, sir.
Thank you very much.
Vijay, sir, for your remarks and opening.
Thank you so much. Thanks everyone for supporting this statistics webinar series. This is the 15th one, and after this there will be one last. And as our General Governing Committee Chair, Professor T.S. Rao said, he's the one who is guiding us and motivating us to do all these things. He picks up immediately what is important, what is not, and he guides us. So his mentor is taken up IJP to new heights. He's guiding us. So our journal, our application for DOAJ from our journal publishers have gone already. So we will find out in about 3 to 4 months. So fingers crossed. So we're relying on our Professor T.S. Rao to guide us forward. Thank you everyone for joining. I hope you have all have good learning today. Thanks, Dr. Ravi and Ravindra. Thanks.
Thank you, sir.
Thank you very much, sir.
Before we'll start, I'll just quickly introduce our today's speaker. I know that most of you know about Professor Ravi Philip Rajkumar, and everyone who had come in contact with sir know that sir is one of the most meticulous person they might have ever met, whether be it in communication or presentation or the knowledge wise, so to up to date and to the perfection. Okay, so as a formality, I'll just introduce sir again. Sir is professor in the Department of Psychiatry at the prestigious JIPMER, Puducherry. Sir has obtained his MD in Psychiatry from NIMHANS. Subsequently, he had been working as a faculty in JIPMER. Sir's interest includes psychopharmacology, comorbidity in psychiatric disorders, and studies of the correlates of mental health and mental health severity service delivery, and at a cross-sectional and national level. Sir is member of editorial board of severe journals at the national and international level, including BMC Psychiatry also. Sir has published more than 150 papers in peer-reviewed journals till date. And also it's important to note, one of the most cited article in COVID about India is by Sir. Sir, so if you look at that has been cited almost 4,500 times. So that is something remarkable feat. From 2020, it was published within a span of 2-3 years. Having 4,500 citation is something unimaginable. So with this quick introduction, I hand over it to Sir. Over to you, sir.
Thank you very much, sir. I would like to thank all of you for your kind invitation, for your kind words and for giving me the chance to participate in this program. I think this is really a fantastic initiative because when we were going through this process, when we were junior residents or senior residents and doing our first papers or writing our first reports, we often had to just learn on the fly. Or if we were fortunate enough to be in an institute like NIMHANS, we would be able to find a statistician and we could outsource these things to them. Now, before I start, I would like to share one concern with Rao sir, which is that I'm also not a master of this topic. But having had the opportunity to review several systematic reviews and meta-analysis for various journals, both Indian as well as international, I would like to share with you some brief points and some experience. This would be of interest not just for those who are reviewing, but also if we are planning to author our own systematic reviews and meta-analysis. Often when we want to prepare for an exam, we go and ask people who have been examiners, what will they ask in the exam? How will the exam be? What would the pattern be like? Same way, when we want to take up this job of writing our own systematic reviews and meta-analysis and making sure that they are of good quality, that they stand a chance when they are submitted for peer review in a good journal, then we also know the other side of the story. What is it that they expect from us? What is it that they are going to be looking for? So with these few words of introduction, I will just start, and it will be an interactive session. I will not, try to lecture a lot or give a lot of information overload. Statistical details will be kept to a minimum because I think there are other experts who can explain it much better than I. And we'll have more space for questions and answers. So all of you will probably be familiar with this diagram over here, the pyramid, which shows...
Dr. Ravi, sorry to interrupt you. Do you want to,
yes.
If you don't use your video, probably the bandwidth may improve because I can see you're breaking up.
I'll do that.
That's all. Yeah, please, thanks.
Sure, sir. That's a good idea. I'll turn off the video and we'll focus on the screen. So all of us are familiar with this diagram one way or the other, which is the hierarchy of evidence in medical research. Before the days of scientific medicine or evidence-based medicine, most of us would rely on expert opinion. If my senior said this, I should do it. Or, if my ancestor said this and wrote it in a book, then that is what is to be followed. Then later on, people started making observations of patients who had the same disease or patients who responded to a particular treatment. And then we started getting into case series and case reports. By the 20th century, we started having a number of cohort studies, randomized controlled trials, which first found out what were the risk factors for particular disorders or diseases, and also found out whether an intervention for that disease was better than no treatment at all or a placebo treatment. After this, what was done was people went back and looked at those original studies and found out what were the strengths and weaknesses of them, whether they had any methodological limitations. And so they started to critically appraise not only the individual articles, but the topics. But finally, what was realized was that instead of just critically pulling out one article and saying, this one was good or this one was not so good, it would be better to have all the articles or all the original research on a given topic collected together in one place and critically appraised together in one place. That is what we mean by a systematic review. If along with this, we are also statistically pooling the data from all these studies together and trying to find out overall what is the difference between treatment and placebo, or those exposed to a risk factor and those not exposed, then we are in the field of meta-analysis. So what is a systematic review? If we want a definition, it is nothing but a meticulous summary of all the available primary research in response to a research question. So the definition has 3 points which are very interesting here. First, it must be in response to a research question. We don't do a systematic review because we are in the mood for it or somebody asked us to do it. There should be a clear, well-formed research question in our mind before we start a review. Second, it should include, as far as possible, all the available primary research. Most of us are familiar with writing a review where we select the most recent papers or the ones that are free for which the full text is available, but those are not systematic reviews. In a systematic review, as far as possible, an attempt should be made to collect all the available primary research. And it should be meticulous. Once you have collected all this together, you have to not only summarize the results of each study, but analyze and find out the strengths and limitations and what the implications of this are for clinical practice of our research. For this reason, because we are actually going to take these papers and do research on them, systematic reviews have also been called secondary research or research on research. According to experts in the field of evidence-based medicine, high-quality systematic reviews are considered to be the most reliable source of evidence to guide clinical practice. Now, we come to the next topic, which is what is a meta-analysis. So if you look at this Venn diagram, you see a big circle of literature reviews. Then you see a smaller circle of systematic reviews. Within the smaller circle of systematic reviews, we see the meta-analysis. So meta-analysis are a subset of systematic reviews where, in addition to collecting all the literature and summarizing it and analyzing it, you also go ahead and use statistical tools to pool the data from the systematic review and to generate a summary conclusion. In other words, at the end of a meta-analysis, you should be able to say, this treatment reduces the symptoms by this %, or this many points on the rating scale, or this risk factor increases the risk of the disease by this much of an odds ratio, or this much %. So a meta-analysis must be based on a systematic review. We cannot just randomly pick up some studies that we like or some studies for which the full text is available and say, I'm going to do a meta-analysis. It has to be based on only a systematic review. And good quality meta-analysis are considered to be the best source of the quantitative estimates for any treatment or any exposure effect. If any of you have the time, you could also read this article by Matthew, which was published in Indian Pediatrics. It was very nice to see that one of the most lucid articles in this topic was published by an Indian author in an Indian journal. It's a very good article, which describes in a very concise way for a beginner how to do a system meta-analysis. Now, some of us who are in the habit of watching superhero movies or reading comics may have heard this quotation from the Roman poet Juvenal, which is, who will watch the watchers? Quis custodiet ipsos custodes. In other words, just doing a systematic review doesn't mean that you have done evidence-based medicine. Somebody has to go back and check your systematic review, peer review it, and see whether it is done of good quality, whether it is of good quality or not. This is especially important nowadays because we see submissions coming which are generated by artificial intelligence or which come from the so-called paper mills where people just write it mechanically and submit to a journal. This problem, fortunately, does not exist in our country, but it is becoming a major concern in some other countries. So unless there is somebody to watch the watchers, unless there is somebody to act like a kind of police and say, I will check the quality of your systematic review or meta-analysis and see whether it is fit to be published, whether it can really be applied in practice or in research, then it's not. Otherwise, without this process, we cannot rely on the systematic reviews. So though it is considered to be the top of the pyramid, this is based on the assumption that they are of good quality. And to ensure this, it is important that we know how to review it. We need to know what to look for, where the common errors are made, and how to pick them out easily. If we go back to the very classic text by Trisha Greenhalgh written in 1997, which is called How to Read a Paper, there it is stated that when you review any systematic review or meta-analysis, you have to answer 5 key questions. So if you're going to write a peer review report, if you're submitting a report to the editor of a journal, whether it is Journal of Psychiatry Spectrum or Indian Journal of Psychiatry or any of our journals, your peer review report has to at least answer these 5 questions. First and foremost, did the review address an important clinical question? If you say, I'm doing a meta-analysis of prevalence of, nausea in patients taking paracetamol compared to those taking placebo, I don't think many people will be interested in this systematic. It has to be an important clinical question. Were databases and other sources thoroughly and appropriately searched? Remember at the beginning, we saw that the definition says it has to be a meticulous review. Meticulous means we try to collect ideally all the information, if not possible, at least as much information. So were the databases and sources thoroughly and appropriately searched? Third, after taking studies from databases, were we able to assess their study quality? Did the people writing the systematic review include some rating of the study quality? Was this a study of good quality? Was it prone to any kind of bias? Then, did the way in which the review is done critically affect the results in some way? Some systematic reviews are very robust in terms of their findings. Even if you remove 1 study or remove 2 studies, the conclusion will remain the same. On the other hand, some systematic reviews are done in such a way that the conclusions are vague. If you remove 1 or 2 so-called positive studies or interesting studies, the systematic review will give you negative results or opposite results. So there are statistical tools to check and see whether removing some studies or including studies only of high quality or including the studies that were only published recently affects the results or the outcomes. And this is called a sensitivity analysis. I'm not an expert in this, but I'm sure there are software packages and experts who can help you with this. And as a peer reviewer, you always have the option to indicate to the editor of a journal that you need a statistician's review. Or you can say that I've taken the help of a statistician in preparing a review. Last but not the least, have the numerical results been appraised in the light of study validity and clinical relevance? So if you got some finding at the end of a systematic review, but all the included studies were of poor quality, you have to give a very cautious statement. Often we will find this when we read Cochrane reviews. Cochrane reviews are very good at appraising the results very critically. So they will say, for example, if we take some examples from psychiatry, they will say risperidone is better than placebo in treating aggression in children with conduct disorder. A pediatrician reading this will get very excited and say, let's give risperidone to all children who create a ruckus. But the next line in the Cochrane review will be, most studies were of moderate to poor quality. So then you have to be very cautious about saying that everybody should get risperidone. So even if there is a numerical result or statistically significant result that your drug is better than placebo, when writing the final conclusion, the authors also have to mention whether the studies were of good quality. They also have to be mentioned whether the result was of clinical relevance. For example, supposing a meta-analysis says the drug is likely to improve the response rate by 2%. That is statistically significant, but it is not clinically significant. If I tell a patient, take this drug and you will become 2% better, the patient will laugh at me. So you must, after getting the results of a review, you must see whether they are clinically meaningful also. A very small difference, even if it is statistically significant, may not be clinically significant. There are many tools and checklists that we can use to assist peer reviews. And this can be used, or this can be kept at our side when one of us is involved in reviewing a manuscript or a draft of a systematic review. The first of the kind was probably the quorum statement and checklist, which was specifically designed for meta-analysis of randomized control trials. So though it was a good statement and checklist, it had a very limited scope. It was only for meta-analysis and it was only for randomized control trials. Later on, by the year 2005, it was expanded to the PRISMA checklist, which covered all systematic reviews and all meta-analysis, not only of randomized control trials, but even of other observational studies, risk factor studies, and so on. Another important tool that we must use when we are reviewing a systematic review is to check whether the review protocol has been pre-registered. And the database where these are registered is called Prospero. Those of us who have conducted clinical trials may remember that when we are doing a clinical trial in India, we have to register with the CTRI, Clinical Trials Registry of India. In the same way, nowadays, many journals insist that if you are doing a systematic review, before even starting the review, you have to register the protocol in this database, free database known as Prospero. Last, but probably the most important, the one that is of most interest and most help to a peer reviewer, is that we have this scale, not really a scale, but rather a checklist called AMSTAR. And the most recent version is AMSTAR 2, which is to assess the quality of a systematic review. So let us just look at all these things one by one with some examples and some illustrations. Starting with the quorum statement, which was first published in the year 1999. It is an acronym for Quality of Reporting of Meta-Analysis. As I said, it was designed specifically for meta-analysis of RCTs. And this quorum statement includes a statement, a checklist, and a flow diagram. The checklist is what I'm going to explain a little more in detail. It includes 6 subheadings and 21 items. So let us look at the checklist one by one. First and foremost, the title. You may be surprised that sometimes people writing a systematic review make errors even in the title. They say a review of this, or an article about this, or they will say a study of this. In the title, it should be mentioned clearly that the paper is a meta-analysis. Second, they have said that when you write the abstract for a meta-analysis, it should be in a structured format. And the headings that they recommend in the quorum statement are objectives, data sources, review methods, results, and conclusions. Now, if this sounds unfamiliar to you, that is because quorum is still a bit old. It is a bit outdated now. We have a different format which we follow now, which is in Prisma. I will explain Prisma in another 2 minutes or so. When coming to the introduction should clearly define 3 questions. First, what is the clinical problem for which you are doing the meta-analysis? Second, what is the treatment or intervention that you are studying and what is its mode of action? Third, what is the rationale for doing the meta-analysis? Why should you be doing it now? In the methods, certain points have to be included. First, the search strategy, the exclusion and inclusion criteria for what papers you are going to put into your meta-analysis, the method of quality assessment for each RCT, the method of data extraction, the study characteristics in a summary table or in a diagram, and proper reporting of statistical methods. Under results, they mentioned that you should include what is called a trial flow diagram. The trial flow diagram given in the quorum statement is somewhat primitive in nature. Nowadays, what is followed is the Prisma flow diagram. Descriptive data on each trial should be summarized, and summaries results for the primary outcomes should be clearly mentioned. If your review is about efficacy of a treatment, you should mention the findings about efficacy rather than the findings about, let us say, adverse effects. On the other hand, if your meta-analysis is about adverse effects, those should be given prominence. Appropriate statistical summaries and figures should be provided. The common ones in meta-analysis are the effect size, the 95% confidence interval, the measures of heterogeneity. I will explain what heterogeneity is in a moment, and sensitivity analysis, which we have already seen. And analysis pertaining to study quality or risk of bias have to be reported. In the discussion, only the key findings should be summarized. A common mistake made by many people who are writing a systematic review or meta-analysis for the first time is that they rewrite the whole results in the discussion. Often the peer reviewer gets irritated and says, please make it shorter. So only the key positive or negative findings should come in the discussion, following which the clinical inferences and the validity should be mentioned. In other words, is this finding of clinical importance, and are the studies of good quality that you can be confident in this finding? Results should be interpreted in the light of the existing literature. If there is previous literature which says that some treatment X is the gold standard treatment, and your meta-analysis is about some other treatment Y or Z, then you must discuss whether Y is better than X. The limitations of your meta-analysis should be acknowledged. For example, you may not have been able to search certain databases, or you could not get some data from some of the study authors, so you could not conduct certain statistical tests. Those limitations have to be acknowledged. And at the end, you must mention an agenda for future research or future clinical trials. Your meta-analysis should be of use to people who are doing future clinical trials. They should know what to do and what not to do. This is the quorum flow diagram. I'm sorry for the poor quality of the image, but this is what was in the original quorum article. I'm sorry about that. So basically, you start with identifying RCTs by searching the literature database, then excluding the ones that are clearly not fitting, doing more detailed evaluation, exclude some, taking some to be included in the meta-analysis, exclude those that don't have numerical data, then include the meta-analysis. If any have to be withdrawn because you couldn't get the data, couldn't get the full text, mention that. And then finally give the summary and outcome. Now we'll move on to what everybody is using nowadays, Prisma, which started around 2005 to 6 and is now updated in the year 2020. Prisma is an acronym for Preferred Reporting Items for Systematic Reviews and Meta-Analysis. It is nothing but an update and improvement of the quorum. It provides a minimum set of information to be reported in any systematic review or meta-analysis, and it has somewhat more subheadings and items. It has one more subheading and it has 6 more items. Remember, the word minimum is very important. Just because somebody fills a Prisma checklist doesn't mean the systematic review is perfect. Prisma checklist is like a pass mark in the exam. If you get 35% or 50%, it means you can pass the exam. Doesn't mean that you have done very well. Same way, a person who has filled up the Prisma checklist and fulfilled it in his manuscript, you can say that they have submitted a manuscript that fulfills some minimum standard for a systematic review. But it doesn't mean that you are necessarily going to accept it without any revisions. Most journals are now very strict that the author has to submit the Prisma checklist and flow diagram when they are submitting the systematic review or meta-analysis. Otherwise, they will ask you to resubmit along with these two. For peer reviewers, what is important is that Prisma can be used to see whether the manuscript is complete, whether any of these 27 items are missing. But it is not a tool that gives you any score or any rating of the quality of the systematic review. You cannot add up the scores at the end of the checklist and say, out of 27 items, 20 were there, so I give it a good quality. No. Prisma is used as a checklist. Is this there or is this not there? It can be used to give advice to the author. Please include this. Please revise this. Please mention this. but it's not a tool to give a rating score like the rating scales that we have in psychiatry. The subheadings of the Prisma checklist are title, abstract, introduction, methods, results, discussion, and other information. This is also helpful for your peer review because when you are writing a peer review report, you can organize this under the same subheading. So let's say you're typing your report in Microsoft Word, you can write title, any changes required, abstract, any changes required. Whereas if there is no change required under a particular heading, you can also mention that. So what do we look for under each subheading? The title, of course, should mention that the paper is a systematic review or meta-analysis, and it should be informative. For example, if I write the title as Systematic Review of Risperidone, that is not a good title. If I write Systematic Review of Risperidone for the treatment of treatment-resistant schizophrenia, that is an informative title. And ideally, if you have details about the methods or the time frame, you can mention it. So if you are doing a meta-analysis with certain specific statistical models or tests, you can mention that. If you are including papers only published in the last 10 years or 20 years, you can mention that. But this is only additional. It is not mandatory. The abstract should cover 4 things. Background to the review, why are you doing it? The methods of the review, results, and the discussion. And in the background, the objectives should also be mentioned clearly. The introduction should cover 2 things. First, it should provide a clear rationale as to why you are doing the review. Why do we need this review? Is it really needed? And second, the objectives should be stated clearly. Under methods, the inclusion and exclusion criteria should be clearly specified. This is the same as quorum. The literature sources should be listed. It is recommended as per Prisma guidelines that at least 2 literature databases should be used for a systematic review. But the number that is recommended can be even up to 12 or 13, depending on how meticulous you want to be. At a beginner's level, at a starting level, it's recommended to have at least 2. The search strategy or search string should be provided in detail. The process of selection and data extraction should be described. And if you have used any software or tools for your meta-analysis, you must mention the name of the tool or the package that is used. The methods of data synthesis should be elaborated upon. Under results, a flow diagram, what is called the Prisma flow diagram, which I will be showing in the next slide, should be provided. A summary of each study should be provided in a table. Risk of bias assessments should be mentioned because bias is the one thing that prejudices any systematic review or meta-analysis. You must mention for each study whether there was a risk of bias. Individual study results should be mentioned appropriately. A descriptive synthesis of results should be provided. Even if you are not doing a meta-analysis, you must at least mention in the text, based on these 11 studies or based on these 20 studies, what was the positive findings, what were the negative findings, what is the overall trend of the findings. Additional analysis of heterogeneity and sensitivity are needed for meta-analysis. At this point, I will just pause for a moment and explain what is heterogeneity. Sometimes when we review all the studies on a given topic, we will find that all of them show similar results. For example, if we take all the trials of, let us say, risperidone for schizophrenia, we will find that all of them will show that risperidone is better than placebo. In other words, all your confidence intervals will be on one side of the midline. If you put a ruler, you will find that all the confidence intervals are sitting on one side of it. Then you say that the studies are relatively homogeneous. You don't need to worry about heterogeneity. On the other hand, supposing you summarize all the trials for some particular treatment which is not well established. Let us say, for example, fluoxetine for alcohol dependence syndrome. And we find some studies show that fluoxetine is better than placebo. But some studies show that fluoxetine is worse than placebo. It makes people drink more alcohol. Then we say that there is significant heterogeneity. So when the study results lie on both sides of the center of the null hypothesis, then we can say that there is significant heterogeneity. And this has to be mentioned and quantified in a meta-analysis, because if there is heterogeneity, you may not be able to come to a firm conclusion that this is better than that, or this is definitely associated with that. In the discussion, the results should be interpreted in the context of what is already known, and 2 types of limitations should be mentioned. Often when an author writes limitations of the systematic review, they write, we know only English, we could get only 2 databases. That's good, that's very good. But you must also mention the limitations of the included studies. If, for example, many of the studies had a very small sample size, that should be included. Or many of the included studies were sponsored by some pharma company, that should be mentioned. Or some of the studies had a high risk of bias because the patients were not randomized properly. That should be mentioned. So when you write limitations, you must not only write your limitations, but the limitations of the people who have done the original research. Other information is the new heading that has been included in Prisma. It has 3 points. First, protocol registration should be mentioned. And Prisma does not say that protocol registration is compulsory, but it says that even if your protocol registration is not done, you should mention that the protocol will be made available to anyone upon reasonable request. Then sources of support, any funding, any possible conflicts of interest should be declared. If your meta-analysis, for example, is showing that olanzapine is better than risperidone, and you are getting funding from the company that makes olanzapine, it doesn't mean you should not do a meta-analysis. You have every right to do a meta-analysis. But the source of funding should be disclosed in the end of the paper. And a data availability statement should be provided. Nowadays, most journals are very strict about data availability. They say that even if it is a meta-analysis or systematic review, all your raw data, all your statistical tables or Excel sheets should be available. If anyone wants to ask for them for a reasonable purpose, they should be provided. This is the Prisma flow diagram, which has 3 components: identification, screening, and inclusion. So in identification, this part deals with the literature search. How many databases and registers do you search? And based on that, how many do you remove from screening? In the first stage, what we do is we remove duplicate records. Let us say I do a search in PubMed and I find 150 papers related to a topic. I do a search in Scopus and I find 220 papers related to the topic. There may be 80 papers that are common to both PubMed and Scopus. So those have to be removed. Records that are marked as ineligible by automation tools. Let's say, for example, you are using some software to find this, to retrieve studies. And the software says this paper was retracted or this paper was removed by the editors for some problem. That will not be included. And any records removed for other reasons. Then the next is screening. So first, the step of screening is to screen only the title and the abstract. Based on that, you can find many things that don't belong in your review. You can exclude them. Then retrieve the reports. If you could not retrieve the report, let's say the full text is not available or it is not in your language, you may have to mention that. Then you get the full text papers and you assess them for eligibility. At this stage, if anything has to still be excluded, let's say it doesn't report the data fully, or it does not fit into the inclusion criteria, that can be excluded. And then at the end, you must mention the number of studies included and the number of reports. Why is this important? Because sometimes one study may have more than one report. There may be one study that reports 2-month outcome of treatment with some antidepressant. The other study will be a continuation of the same study done by the same authors, which will report 6-month outcome of treatment with the same drug in the same population. So number of studies and number of reports may not always be the same. Sometimes there may be more than one report for a single study. Now we come to the pre-registration of the protocol. I will stop and take a little time to talk about this because this is something that we are a little less familiar with. Even when I started doing systematic reviews, I had to learn about this from the beginning. So as per the Prisma checklist, it is recommended that a systematic review protocol should be pre-registered, just as we pre-register the protocol of any clinical trial on CTRI. In some journals, it is mandatory, and they will not even send your paper for peer review without pre-registration. They will reject it from the editor's desk and say, please resubmit to the pre-registration. The name of the registry for protocols of these systematic reviews and meta-analysis is Prospero, and it is managed by the National Institute for Health and Care Research in the United Kingdom. Registration is free. You will have to create a user ID and password just as we create in any website or journal website. And then you have to upload your protocol document and fill in a certain form over there. This is the link for registering on Prospero. Sometimes you will find that some meta-analysis which are not of good quality will try to register on what is called Open Science Forum. Now, Open Science Forum is basically a place where you can upload your project protocols to share with others. But there is no process of screening or quality assessment in Open Science Forum. You can upload anything in Open Science Forum. Even if you say randomized control trial of drinking water versus drinking salt water for bipolar disorder, you can upload this in OSF, nobody is going to stop you. So the problem with OSF is it is a good tool for sharing data between researchers, but it doesn't give a quality check. So most journals will insist on registering in Prospero. Why should we pre-register? You may ask, why should I put my protocol there for the whole world to see it? Is it needed? First and foremost, it is needed for transparency. Because meta-analysis and systematic reviews are the highest quality of evidence, there has to be transparency in how they are done. If we try to hide the process by which they are being done, whether we have done anything wrong or not, later on somebody can question our transparency. And we know that we live in an age where people are very skeptical about biomedical research. If we say that some vaccine is safe, people will say this is very dangerous, it causes death. If we say that this drug is safe, they will say, no, the company hid a lot of data about it, which may or may not be true. But you should not be put in the position where you will be blamed for it. So pre-registration ensures that you are showing to the world that you are transparent. Second, pre-registration allows replication. If your protocol is registered and it is done and you get some findings, later on 10 years or 20 years later, when you have retired or you are no longer doing systematic reviews, if somebody else wants to repeat the review with a lot of new data or new studies, they can replicate. They can take and say, so-and-so, Dr. TSS Rao's systematic review was of very good quality. Or Dr. XYZ's systematic review was the one that is the gold standard in our field. So I'm going to replicate. I'm going to use the same protocol. Only thing, I'm going to take a lot of new studies. The other advantage of pre-registration is to minimize bias. By pre-registering, by making sure that our protocol undergoes some quality check, we are minimizing any source of bias that may creep in if we try to make the review give a particular finding. Probably one of the most important reasons for pre-registering is to prevent duplication. When we pre-register, sometimes the protocol may be rejected by Prospero because there is a very similar protocol already going. In that case, that doesn't mean you cannot do a systematic review, but you may have to change your topic. So it helps to avoid duplication. And ideally, ultimately, the aim is to have better communication between professionals. For peer reviewers, this is where if you want to be like a detective, if you want to be like Sherlock Holmes, you can, use your detective skills. Go to Prospero, download the protocol by searching the protocol number, compare it with the manuscript and look for any discrepancies. You can find out if the authors have tried to do any tricks. Even if there is a chain discrepancy, at least the author should explain why there was a discrepancy. If there was a discrepancy and it was not explained, then you have to be a little suspicious that some bias or some lack of transparency has crept into the review process. This doesn't mean that the authors are bad or have done anything unethical, but it means that in your review report, you must mention, in Prospero, you have mentioned the inclusion criteria as ABC. In your systematic review, you have mentioned it as ABCDEF. Why were the two additional inclusion criteria mentioned? Please provide a reason. That's all you need to do in your peer review report. Now we come to the real, main course. So far, we have been having only the starters, soup, cool drinks, but now we come to the main course. The main course is what is called AMSTAR and AMSTAR 2. AMSTAR is an acronym for a measurement tool to assess systematic reviews. It was first developed in 2007, about a year or two after Prisma, and it was revised to AMSTAR 2 in 2017. The purpose of this tool is to be to be an aid, to be of assistance to peer reviewers, editors, and people who are appraising evidence. So it is designed to critically appraise systematic reviews, but it has a focus on randomized controlled trials. The original version of AMSTAR has 11 items. You add up the score and you say at the end, the paper is scoring, the systematic review or meta-analysis scores so much out of 11. The revised version has 16 items and it gives an overall rating, but not a total score. Now, to understand why they removed this total score, let me explain it in this way. Right now, we are in exam season. Some of us may be even getting consultations from +2 students or 10 standard students who are complaining of anxiety or depression. So since we are in exam season, I will use an example for exams. Supposing there is a student who gets 100 out of 100 in English, 95 out of 100 in second language, 95 out of 100 in science, 100 out of 100 in social science, but 0 out of 100 in mathematics. This person has done excellently in 4 out of the 5 papers, but he has failed the 5th paper. Can we pass this candidate? Obviously, no. He has to be detained and told to write the mathematics exam again. So the reason for removing this total score and giving importance to all the items is that even if one item is done very badly or very poorly in a systematic review, it may invalidate the study findings. You may have to detain that review and ask them to make revisions or to make corrections. So the AMSTAR 2 follows the mentality of our board exams, if I can put it in very common language. So for peer reviewers, this instrument is for you. This instrument is not so much for the authors. For authors, there is Prisma, there is pre-registration in Prospero, there is Quorum. But for peer reviewers, AMSTAR is your best friend. So I will just list the 16 items of AMSTAR. I'm not going to go into each of them in detail because they're quite self-explanatory. Each of these is answered as yes or no. And the criteria for when you answer yes, when you answer as no are given in the AMSTAR manual, which is available free online. If you want, I have the PDF document. I can show it after the slides are over. So the first item is, did the research questions and inclusion criteria include the PICO? So PICO is considered to be like a kind of gold standard for framing research questions. It means population, intervention, comparator, and outcome. So when framing the aims and objectives and the inclusion criteria for your systematic review, was the study population well-defined? Was the intervention well-defined? Was the comparator group like placebo or treatment as usual well-defined? And were the outcomes specified? Second, was it clearly stated that the protocol was finalized before starting the review? This is where you have to go to Prospero and check. Were any deviations from the protocol explained? Sometimes you cannot avoid a deviation in the protocol. Let us say, for example, you find that there are no studies fulfilling certain criteria, but there are many if you make the inclusion criteria different. You may have to change the protocol and even re-register your protocol. Was the reason for inclusion of specific study designs explained? This is important because some systematic reviews try to do a trick. Ideally, systematic reviews should include controlled clinical trials, randomized controlled trials. But some of them will also include non-randomized trials or open trials. Generally, this is frowned upon, but sometimes when you need evidence, it is permitted. But the author should explain why you did not include, why you included studies other than randomized controlled trials. Was a comprehensive search strategy used? In a recent paper that I was asked to review, the person gave the search terms as depression and psoriasis. I resented back saying this is not acceptable. Depression, they will get thousands of records about depression of T-cell mediated immunity, depression of WBC count by people taking steroids for psoriasis. It's not a correct search strategy. Moreover, you are missing out many other key terms like psoriatic or depressive disorder or major depression or depressive symptoms. So the search strategy has to be comprehensive. You cannot just give 2 or 3 keywords and say, I use this. Was the study selection done in duplicate? I forgot to mention this, but when you are registering a protocol in Prospero, they insist that the review should have at least 2 authors. If you try to submit a systematic review protocol on Prospero as a single author, it will be rejected. Believe me, I have tried it also. So, study selection should be done in duplicate. In the systematic review, the author should write that 2 people independently selected the studies. And if there was any disagreement about which to select, which not to select, it was resolved by the discussion by a third party or by between the 2 people. So study selection in a good systematic review should be done by a duplicate. That is by 2 or more of the investigators who are writing that systematic review. The same applies for data extraction. If one person extracts data and he has some bias, he or she may include only positive findings or positive studies. 2 people do it independently. This is less likely to happen. Were the excluded studies listed and were the reasons for exclusion provided? In a review which I had the opportunity to review recently, a systematic review, it was said that out of 30 studies that were retrieved, 18 were excluded. Now that is a kind of a red flag because of most of the studies that you have included have been excluded. Why? When we asked the authors to provide an explanation, they withdrew the paper. So clearly some funny thing was going on there, some strange thing was going on there. So when studies are excluded, you have to exclude some studies. They may not be of good quality, they may not be suitable, but the reasons for exclusion should be provided. Were the included studies described in enough detail? Was it just mentioned we took 20 studies? Or was it mentioned that this study was by so-and-so, done in this country with this many patients? This was the outcome to measure used. This was the dose of treatment used. This was the result. Was the risk of bias assessed adequately? I will come to this in a moment. There are some tools that you can use to assess the risk of bias in randomized controlled trials. Were the funding sources for the review report? This is especially important for RCTs of pharmacotherapy, where the possibility of some conflict of interest may arise. Items 11 and 12 apply only for meta-analysis. They are not applicable for only systematic reviews. If it is a meta-analysis, were the appropriate statistics used to combine results? And after combining the results, was the risk of bias assessed when interpreting the results? So in other words, if at the end of a meta-analysis, you found drug A was better than placebo with an odds ratio of 2.2, you have to also mention that out of the 12 studies included, 8 had a high risk of bias. If you don't include that statement, then this item will be scored as no. Was the risk of bias addressed in the discussion? You will see that there is a lot, there's a lot of emphasis and overemphasis even, you can say, on risk of bias. This is because nothing contaminates a systematic review or meta-analysis like risk of bias. Once your source data is contaminated, the outcome of any review or meta-analysis also becomes contaminated. So many of these tools, whether it is AmStar or Prisma, they insist that risk of bias has to be rigorously addressed in the methodology, in the results, and also in the discussion. Was heterogeneity in results addressed and explained? We talked about heterogeneity. Some studies giving a positive finding, some studies giving the opposite finding. Then, was any method used to check for possible publication bias? There are methods by which, you can do what is called a forest plot or a funnel plot and look for publication bias. Ideally speaking, in publication, there is always going to be some publication bias. We cannot be without it. But did the persons doing that meta-analysis or systematic review use any method to check for it? And were the conflicts of interest reported by the authors of the systematic review? Each of these items is answered yes or no, and there is no total score. A reviewer should consider all the points when preparing the review report, and particular attention should be paid to the items related to risk of bias. Remember, as a reviewer, you are not a film critic. You are not there to say, this was horrible, this was dreadful, this was awful, this was worst, We read that in movie reviews. But a peer reviewer is not a cinema reviewer or a music reviewer. A peer reviewer has to be scientific and has to be objective. So instead of saying this was bad or this was not good, we have to say this item had some limitations, or this item was not addressed by the manuscript, or this item was missing from the manuscript. It has to be given in objective language or scientific language. Apart from all this, I would also like to touch upon some issues that reviewers should consider. First and foremost, is the objective suitable for a systematic review? Not all reviews need to be systematic. For example, there is a very excellent review paper in Indian Journal of Psychiatry called The Story of Dart Syndrome. Now, you cannot write a systematic review about the story of Dart syndrome, because to tell the story of Dart syndrome, you have to include observational studies, interventional studies, epidemiological studies, hospital-based studies, which cannot be pulled together to make a systematic review. So, some objectives lend themselves best to a narrative review or scoping review, where you cannot do a systematic review. That doesn't mean they are bad. All kinds of reviews have their own place and have their own role. So if you are writing the story of Dart syndrome or the story of culture-bound syndromes in India, go for a narrative review. If you are writing recent findings related to immunization status in patients with mental illness for COVID-19, you will need a scoping review because it's only 3 years old topic. You cannot find that much for a systematic review. On the other hand, if you are want to find the efficacy of some intervention, or you want to find the risk factor association for some mental disorder, then systematic review and meta-analysis are the ideal method. Second, is there an existing recent systematic review or meta-analysis addressing the same objective? I once got caught like this. I was sent a paper to review. I reviewed it and said only minor revisions are required. The reviewer too rejected the paper, saying that one review has been conducted in this topic 1 year back. What is the new thing that is going to come in 1 year? So after getting that experience, which was quite embarrassing for me, I always do a search and see if any recent systematic review or meta-analysis has been published in that field. And if so, generally it is better either to tell the author to wait for some time or to focus on some other outcome rather than whatever they are doing. If the review is an update, sometimes people will say systematic review update or systematic review of the last 10 years. You must mention how much original research has been published. You must look and see whether the authors have mentioned how much research has been published since the last review. The reason being, if only 2 studies have been published since the last review, there's no point in doing another. Third point, do the search terms match the study objectives? One easy trick that you can do is take the search terms yourself, put them into PubMed and see how many citations you find. Sometimes the people, I have seen peer reviews, I once got a paper to review where they said PubMed search was not done because after typing the terms into PubMed, we retrieved 85,000 citations. I typed in the same terms, I found 400 citations. So I told them there is some mistake with your software. So then they went back and checked and found that there was some mistake on how they had entered in the software. It was corrected and the paper proceeded for publication. Are relevant studies excluded for unclear reasons? Sometimes while searching for this topic, you may find papers that seem to be very relevant. If you find that as a peer reviewer, you have every right to ask the authors in your review report, why was the study excluded or why was it not included? Did the authors use appropriate tools to assess risk of bias in the included studies? Talking about assessing risk of bias is a totally different topic, but I would just like to mention two tools here. The Cochrane Risk of Bias tool, which is available at the Cochrane collaboration website, is used to assess risk of bias in clinical trials. But very often in psychiatry, we like to do systematic reviews of observational studies, like association between childhood trauma and psychosis, or association between prenatal valproate exposure and autism in the child. So to assess the risk of bias in observational studies, there is another tool known as Newcastle-Ottawa rating scale. This scale can be used to assess the risk of bias if it is not a clinical trial, if it is an observational study or epidemiological study. In a meta-analysis, are the statistical analysis appropriate? And if you need help, you can always ask for the help of a statistician. Or sometimes the journal will give you an option in the review report where you can click, does this manuscript require specialist statistical review? If you click on that, your worries are over. They will find somebody in-house who will do the statistical review. Did the authors have expertise in the concerned field? Are they qualified to carry out a systematic review? Like I once was sent a systematic review on, mental health concerns during COVID-19 in India, where the two co-authors, one was from an Institute of Management and the other was studying social work in college. Now, I don't mean to insult any discipline, but you need experience to do a systematic review. I will not recommend even an MD psychiatry resident to blindly do a systematic review. So if the authors do not seem to have the expertise in the field, you must check whether they have consulted any expert or whether they have consulted any, person who has experience in medical research or in biostatistics while writing their review, and whether they have acknowledged that while writing the acknowledgements of their paper. Last but not the least, are the recommendations and conclusions balanced or exaggerated? Sometimes you may find a systematic review that is wonderfully written, but that last paragraph of conclusions will not be suitable. Recently, someone sent me a paper to review, which was about some medications for sleep. It was comparing zolpidem with some other drug. And the review was done very nicely. But the last paragraph said, this systematic review shows that this new drug is a revolutionary treatment for sleep disorder and it markedly outperforms zolpidem. Experts in sleep medicine should be advised to prescribe this medicine as far as possible. This kind of exaggerated statement, it raises a lot of questions. Why are they making such a, glowing statement to favor one drug over the other? Instead, you can say this drug has significant advantage over zolpidem in terms of safety and efficacy. The statement can be made, but it should be made in a balanced way. You're not there to praise or to blame anyone. You are there to scientifically appraise the evidence. That is what the authors should do. So to sum up, before we move on to the questions, systematic reviews and meta-analysis are like the apex of the pyramid of evidence-based medicine, but they are only as good as they are of good quality. A poor quality systematic review or meta-analysis doesn't have good evidence-based value. The peer reviewer's task is to assess each domain of the systematic review, whether it is abstract, introduction, objectives, methodology, results, discussion, or reporting of bias or registration objectively. The aim of the peer reviewer is not to criticize or to hurt the authors. It is to help them to improve their work and finally to give a systematic review that is helpful to clinicians in treating their patients or in doing further research. An otherwise good review, even if it is severely flawed in one domain, may need to be revised or rejected. Do not be carried away by, the systematic review had everything nice, but results were not good or search string was not good. There is nothing wrong in asking the author to revise. And the use of existing tools and checklists can make the review process easier and more objective. So with this, I will end. I will just stop here. But, I thank you very much for giving me the chance to speak on this topic and, to just give you an overview of how we go about reviewing a systematic review or a meta-analysis. And the topic is open for questions. And if you would like to have a look at some of these tools also, for example, there is a very nice book that has been published by ICMR, not this one. I'm so sorry. This is the wrong one. Yeah. It's called Beginner's Guide for Systematic Reviews. This is available for download on the ICMR website. It was published as part of the 75 years of Indian independence. And this gives a very nice step-by-step guide to conduct systematic reviews and meta-analysis. This is very useful for us, many of us who are trying to do this for the first time or whose students may be trying to do it for the first time. And it is also very useful for the person who is going to review or who's going to be the editor of the journal. to which they are going to submit some meta-analysis or systematic review. So this book is a good book which is available free online, which is relevant for the Indian context.
Yes. Yeah. Thank you, sir. There are a couple of questions in the chat box, sir. We'll take, then we can proceed with other things. First question is by Professor Bidjar. He is asked, like, sir, kindly explain again about the risk of bias.
Thank you, sir. I think this is a very important topic. Sir has asked, what exactly do we mean by this risk of bias? There are many sources of bias in a clinical trial, but when we are talking about specifically randomized clinical trials, we want to know if certain procedures have been followed properly. First and foremost, for randomization, is the study a randomized study or a non-randomized study? The purpose of randomization is to try and avoid bias, to make sure that the 2 groups or 3 groups are as comparable as possible. So randomized trials are less open to bias than non-randomized. Second is the randomization method described. There are many ways of randomizing, using a sealed envelope, using a computer, using a random number table. But did the authors of the original paper report the method? Sometimes they may not have done it, but they will just say randomized control trial. So if it is not mentioned, again, that raises the possibility that there was a bias, that the randomization was not done properly. Then blinding. Remember, bias is not just something that affects the researcher. It may also affect the person who is doing the rating scale. Supposing a person is rating a patient and he knows that the patient is getting a new drug. If he likes the drug, he will give very favorable ratings. He doesn't like the drug, he will say the drug causes horrible side effects. So the rater should also ideally be blind. The patient receiving the treatment should also be blind to what they are receiving. So the process of blinding should be described in the report of the clinical trial. Then how the blinding was done. Blinding is just saying that the patient was blind, the rater was blind. How the blinding was done, what precautions or what steps were taken to hide the allotment from the clinician and from the patient, that is known as allocation concealment. So did the authors of the trial report how the allocation concealment was done? Even if randomization, blinding, and allocation concealment have been done pakka using very secure technology and passwords and sealed covers and so on, there is still the possibility that your trial may have bias because of dropouts. If a large number of people drop out from a study and you analyze only the data for those who remained in the study, you may get a very different picture from what happens if you analyze the dropouts. So did the authors of the study of the controlled clinical trial analyze the dropouts? Did they use any appropriate analysis method like last observation carried forward or baseline observation carried forward? Or if it is a very large data set, sometimes they do what is called random imputation. So was the method of handling dropouts described? So when we look at risk of bias in a controlled clinical trial, we basically are looking at 4 things. Was randomization done and described properly in the paper? Was blinding done and described in the paper? Was the method how blinding was accomplished? In other words, the allocation concealment described in the paper, and how are the dropouts from the trial? That is these are basically the 4 steps that we look at when we do risk of bias. In an observational study, it is a little more complicated because in an observational study, there are far more confounding factors. But if you look at the Newcastle-Ottawa tool, that might give you an idea of what it is that we are looking for. So if we look at the Newcastle-Ottawa instrument over here, it tells us, for example, did we ensure that the 2 groups we are comparing are comparable in other ways? Did we ascertain the exposure by some, objective method? Did we use the same method of ascertaining the risk factor for cases and controls? Did we handle people who dropped out of the study? Did we make sure that the study was representative of the general population? So these are some of the things that we would look for in an observational study.
Thank you, sir. There are some more questions in the chat box.
Ma'am has asked, could you elaborate on meta-analysis as a topic?
Yes, Shubhangi ma'am has asked.
Sure. So again, I would like to emphasize that I'm not the greatest expert in the field, and I'm approaching it from the perspective of a peer reviewer rather than, a master of data analysis or a Cochrane collaborator. But a meta-analysis is a systematic review with a statistical component. The purpose of a meta-analysis is that you may have many individual studies that show some findings. Individually, those findings may not be statistically significant because the study sample may have been a bit too small. The classic example is the trials of giving steroids to the premature infant so that they don't have the lung disorder that occurs in premature infants. The lung collapses and they develop respiratory distress. So there were many trials which showed that steroids were better than placebo in these infants. But because of the small sample size, people rejected them or said they are giving only marginal significance or trend to significance. But when these studies were pooled together in a meta-analysis, it was found that this steroids is definitely better than placebo. And nowadays it has become like a routine practice in pediatrics or in neonatology. So in fact, if you look at the Cochrane website, or even if you look at our ICMR manual, that picture is used on the cover. If you look at this picture over here, the one which is below the text, Beginner's Guide for Systematic Reviews, this is nothing but the diagram showing the confidence intervals for 1, 2, 3, 4, 5, 6, 7 trials of steroids for lung disease in premature infants, with the final pooled data showing that the drug is better than the placebo. Of course, meta-analysis can also be done for risk factors. In a meta-analysis, we are trying to look at 3 things basically. The first thing is, after pooling all the data together, is there a significant difference between the 2 groups? Are the people exposed to air pollution more likely to develop cancer than those not exposed? Are the people who take the drug A more likely to respond than those with the placebo? And not only should you get a yes or no answer, you have to get a statistical estimate. Usually it is expressed in terms of the odds ratio and confidence interval. The odds ratio meaning people taking this treatment are this many times more likely to improve or to respond than those who don't take it. Or people exposed to this risk factor are this many times more likely to develop some disease than those who are not exposed to that risk factor. The second thing we look for in a meta-analysis is the analysis of heterogeneity. This becomes important in certain kinds of research. For example, if you look at the literature linking, air pollution and depression, there are some studies which show high air pollution, high depression. There are some studies that show no effect. There are some studies which show in countries with low air pollution, there is more depression, probably because those are developed countries where there is better diagnosis of depression. But all the same, that means that there is heterogeneity. The studies are lying on both sides of this median line. Some studies are positive, some studies are negative, some are null hypothesis. So then you need a statistical test to find out how heterogeneous the studies are. There are various tests for that. There are, even macros that you can download and add to your Microsoft Excel that will do this for you automatically. But you need tests of heterogeneity. The third thing that we do in meta-analysis is tests of sensitivity. We have included 12 studies and we have got some finding which shows which is positive or which is statistically significant. Suppose we remove the most significant study or the most recent study. Is the result still significant? Suppose we remove the studies that are of poor quality. Is the result still significant? Suppose we remove the studies that were conducted in some highly biased sample. Is the result still significant? That is called sensitivity analysis, where we try to take out the studies one by one and see whether the results still remain significant. Another way of doing a sensitivity analysis is to say that after you have got a positive result with 12 studies, you can calculate how many negative studies would be required to overturn this. Sometimes, especially in modern meta-analysis, they will report. Based on these 20 studies, it would require at least 25 more negative studies to change the meta-analytic finding. They will report it in that. So the advantage of a meta-analysis over a systematic review is that it is quantitative. A systematic review may tell you some new antipsychotic is better than risperidone. But the meta-analysis will tell you risperidone is this many times more likely to, the new drug is this many times more likely to give response than risperidone. The amount of variation in the study trials is this much based on the statistic of heterogeneity. And we can be this much confident in the outcome based on the results of the sensitivity analysis.
Yes, sir. Some other question is by Professor Rangnath Kulkarni.
Sir has asked, as a reviewer, how do we know which articles are excluded by authors?
Yes, sir.
So this is a very good question. I thank sir for asking this because I sort of brushed over it when I was talking. Thank you very much, sir. So as a reviewer, often we are, like sir said, we are not privy to this knowledge. They will just give a Prisma diagram in which it is said that 20 articles are excluded. Sometimes what will happen is this information will be available in the supplementary material, where they will give a whole list of citations in an Excel sheet and show that this many were excluded for these reasons. But if there were many studies excluded and there is no data in the supplementary material, we are well within our rights as the editor or as the peer reviewer or co-editor to request the author to provide this information to tell them we have excluded 6 studies in the last step. Why was excluded, or what were these studies and why were they not included? Or at least to provide the reasons for exclusion, or to provide the digital object identifier for those trials, so that you can look at it and see whether they were really fit for inclusion, or whether the author did right to exclude. So if sometimes it's in the supplementary material, sometimes you may need to ask the author.
Yes. There is another question about whether it can be conducted for qualitative studies. If yes, whether the process, checklist, etc. remain the same.
Thank you very much. I think this is a wonderful question, because nowadays we see a lot more Indian studies of a qualitative nature, which are of really good quality. Recently I reviewed one very nice study on a very good piece of qualitative research, which I can say is up to the standards of international authors, or if not better than them. So since there is a growth of qualitative research and trying to understand the experiences of the care patients, caregivers, healthcare workers, naturally the question arises, can we do a systematic review? And the answer is yes. We cannot do a meta-analysis, because obviously the word qualitative itself means there is no numerical component. We cannot pool the qualitative studies together and say, this many percentage of people were satisfied with the COVID vaccine, or this many percentage of patients were satisfied with the telemanaged program. Cannot give numbers. But there are guidelines for conducting the systematic review for qualitative studies. In fact, if you go to the PRISMA website, they will give you the PRISMA checklist modified for qualitative studies. There are different PRISMA checklists for qualitative studies, for clinical trials, for observational studies. You can download the one which is appropriate and you can use that. And if you go to the Equator website, Equator is the website which accumulates all the rating scales to assess quality of different kinds of studies. You will find there that along with this, Quorum and Prisma and AmStar, which we talked about, there will be rating scales to assess the quality of qualitative studies also. So you can download the appropriate scale from Equator, and you can do a systematic review of qualitative research using the Prisma extension for qualitative research.
Another question is there any specific guideline or a way for writing discussion in systematic review?
That's a very good question, because it's like there is no single guideline. But I would just like to answer this question by coming back a little bit to what the 3 guidelines have said. If we look at Quorum, it says that you have to mention key findings, clinical inferences, validity, existing literature, limitations, and future research agenda. If we look at Prisma, it says that we have to mention results in the context of current literature, limitations of the included studies, limitations of the review, and recommendations not only for research, but for practice and policy. How is it relevant for clinicians or for people making practice guidelines or, mental health policy or programs? Same way, AmStar gives certain statements where they have to, where they say that in the discussion, certain key points have to be mentioned. One is whether the risk of bias has been addressed. They have not mentioned anything else specifically in AmStar. So if we pool all these things together, we can say that a discussion, if we add all these things together from Quorum, from Prisma, and from AmStar, we can say that a discussion has to have about 5 or 6 components. The first is a brief summary of the systematic review or meta-analysis findings. Second is appraising the quality of the included research, including the risk of bias and how it affects the confidence that we can have in these findings. The third would be comparison with the other existing literature on other types of treatment and how it fits into it. The fourth would be limitations of the included papers. The fifth would be limitations of your review process. And the last would be the recommendations for clinical practice, research, and if it is relevant, also for public health. So if your study finds that, for example, air pollution is associated with schizophrenia, then you have to definitely say that this is of public health importance. You want to tell people who are involved in public health or in, environmental control regulations that air pollution is a risk factor for mental illness. You want to tell them that. So that last section has to include, the conclusion should not only include research recommendations, it has to include also the recommendations for clinical practice and for policy, if it is relevant.
Yes. So there's another interesting question about what to do about blinding in the studies for therapies. So
this is an excellent point, sir. I think, in psychotherapy research, so far I have made the same mistake as those who made Quorum. That is, I was talking only about drug trials and randomized control trials. But in psychiatry, we also have to deal with psychotherapy trials. Now, most of the time, we cannot do formal blinding in psychotherapy research. It's not possible to do. The only thing we can do is we can ensure that the rater is blind too. So in psychotherapy research, a patient can never be blinded. Once the therapist starts talking to the patient will have some idea that this is CBT or this is IPT or this is EMDR or whatever it is. But at least you can do single blinding. You can have an independent rater who rates the improvement of the patient after receiving therapy. And that person can be blinded to whether your patient got EMDR or got hypnosis or got yoga or whatever was the treatment given. So single blinding can be done in therapy trials. It is a limitation of psychotherapy research, but it is universal in all psychotherapy studies. So single blinding can be.
Yes, sir. These were the questions which are in the chat box, sir. Definitely this session was useful. The one thing what we find is like, as such, there is no training available for these sort of either systematic reviews or meta-analysis. So having a peer reviewer in this area is very difficult. We may hardly get very few peer reviewers. Empowering peer reviewers is of importance, I feel, sir. And also there is another statement.
And I think also as we become more experienced in doing it, we will instinctively look for certain things. For example, the first time we do a peer review, we will always be keeping the AmStar next to us and seeing if the person who's doing it has fulfilled all those 16 points. But later on, we will instinctively look at the title and say, did he mention systematic review? Did she mention the objectives of the study? Did the authors mention the risk of bias assessment? So after some time, it's also a question of practice makes perfect. And I think we should also develop the culture of encouraging, our own authors, our own, young upcoming, not necessarily trainees, but at least those who are starting in their careers, early stage of their career or research, to engage in some systematic reviews, because the number of topics is potentially endless.
Yes, sir. What do you suggest for directly reaching systematic reviews, or they can start with the scoping review, etc., then they reach here? What do you suggest?
I think all have their own merits, sir. To start with, very often what happens is the MD resident themselves are doing a narrative review or scoping review when they write the review of literature for their thesis. So I think they can take that as an experience, and they can even be encouraged. I see this happening in other disciplines. I see PhD scholars who study psychology in Pondy University or in other private medical colleges. They are told that whatever they write as their review of literature, they have to submit as scoping review or narrative review, and they get 1 or 2 publications out of them. So that is a good starting point, where we can do it. And one thing that the guide can do or that the mentor can do during this time is to teach the resident to improve their search strategy, how to frame the search strings. Because very often a newly joined trainee who doesn't have any prior experience of using any PubMed or Scopus, they will type obsessive compulsive disorder and bipolar disorder, and they will stop with that. Only a person who's experienced will know that obsessive compulsive may or may not have a hyphen. Some will write OCD, some will write OCS, some will write obsessive compulsive symptoms, some will write Y-box without writing OCD. And then all these terms have to be included. So I think during the process of thesis training, some introduction to the literature search could be incorporated into the PG training, into the orientation. And then later on, when they come to the senior resident level or junior faculty level, then they could take up a scoping review, which is the next step. Because for scoping review, even if you don't do all these things that are mentioned in AmStar, you still have to follow the PRISMA checklist and PRISMA guidelines. There is a separate PRISMA for scoping reviews. And then with that expertise, there's a lot of overlap there. Then we can move on with more confidence to a systematic. Of course, this is different if you have a mentor or a trainer who's very experienced in systematic reviews. In that case, they can teach you directly. But if you are a beginner and you are learning from scratch, from the ABCs, it's always better to start low and go slow.
Yes, sir. Thank you for this excellent presentation. Also, last what you have mentioned about how gradually the trainee can be trained right from his postgraduate days till senior residency and subsequently also. How the skills can be upgraded gradually. As you rightly mentioned, it's a continuous learning process, sir, and we need to upskill ourselves to have a better output. Because as your first slide has mentioned, the quality of evidence or the merit of evidence, the highest one is this. So we have to reach to this level by empowering ourselves with all these inputs. Okay. So I think those were the questions in the chat box.
There is one more, Ravindra, there is one more
Sir.
clarifying.
Okay, so this single binding will become a bias in assessment of risk of bias. That one, sir.
Yeah.
Yes, it would become a source of bias. But again, if it is unavoidable, then we have to just proceed with it. There are certain treatments where the risk of bias becomes unavoidable. Same thing applies even for surgeries. Like if we are comparing surgery versus pharmacotherapy, we cannot do dummy surgery on the patient. Some people have advocated it. Some people who are very much hardcore into evidence-based medicine have said, give one group surgery, other group you just make an incision and suture it and tell them that it is surgery. But all this is highly unethical. It is only in theory that we can discuss these things. So in some interventions, we just cannot avoid this. And we have to just mention that this is inherent in the type of research that is being done, like in surgery or in psychotherapy, or for example, electroconvulsive therapy, TM. In TMS, for example, that problem doesn't arise because just by angling the electrode at a different angle, you can give real TMS or sham or TMS. But for most of these other interventions like ECT, surgery, psychotherapy, group therapy, family therapy, then we cannot avoid the risk of we cannot avoid it. It's part of the research protocols.
Yeah. Not even a limitation. Not even limitation.
Not even a limitation. That's right. It is inherent in the type of research that's being done.
Yes. Sir. Yeah. Thank you, sir. Vijay sir, we're left with another 5-6 minutes.
I think I was sitting back and just listening, and it was a feast of information. Though it's too much, but we needed that at the right time. If you can see, there was for the first time in 15 sessions we have conducted nationwide, more than 65 had attended today. I think, and everybody is full of appreciation of your talk. It was very lucid, to the point, and it was very easy to understand what you are trying to explain. Also, I think what Shubhangi ma'am also mentioned, that she wants to listen to this again, so she wants a recording. So that itself tells you.
Thank you,
I should thank you very much. At the right time, I wanted it, and you got me. Thank you so much, Professor Ravi. Thank you so much.
I'm honored to always take part in these programs, and I really appreciate that you have thought of me and given me the invitation to take part in this program. I should appreciate your initiative in taking the topic of biostatistics and research methodology in such depth.
You're part of editorial board anyway, so we make use of you to the maximum. To the maximum. Yeah, and thank you so much.
We should thank all the audience who have participated actively, and
absolutely, absolutely.
Last 15 sessions. Okay, so thank you all.
Yes.
Thank you all our associate editors and our reviewers and our office bearers also for being part of this journey. So as mentioned, we'll have one more session in the March 20th or so. Then we'll be winding up our statistics webinar series. We'll see, like we are thinking of having a feedback from all those who have attended down the lane.
Okay. Stop recording and
yes.
Thanks, sir.
Thank you. Thank you, Ravi sir. Thank you,
Thank you very much, sir. Thank you, sir.